Hello everyone, my name is Annika and I'm a fourth year medical student at the University of British Columbia. Today we will be talking about necrotizing fasciitis, a rare but life-threatening soft tissue infection. Before we get started, I'd like to thank Dr. Ola Lutsev, a UBC plastic surgery resident, and Dr. Janine Roller, a plastic surgeon in Vancouver, for their support in creating this video, as well as the other fantastic plastic surgery videos on this page, which we encourage you all to check out. Our goal today is to provide an overview on the topic of necrotizing fasciitis. Specifically, we will review the pathophysiology, identify the important signs and symptoms, and review treatment principles. Now, infections of skin and soft tissues comprise a large range of pathologies that plastic surgeons will come across during their practice. To simplify matters and aid with diagnosis, we often divide these infections into purulent and non-purulent, meaning whether pus is present or not. We can also separate them out into simple, such as a localized monomicrobial infection, or complicated, such as a mono or polymicrobial infection with systemic findings in a progressively unwell patient. Common skin and soft tissue infections are often attributed to staph and strep species. Necrotizing fasciitis is a complicated, purulent skin and soft tissue infection and is often referred to colloquially as flesh-eating disease. Following trauma to the skin, an infection can develop and spread within fascial tissue. Now, these fascial planes are more avascular than surrounding muscle and other soft tissues, which means that symptoms can take longer to become evident. As the infection travels along these planes, the surrounding tissues eventually become affected, and patients begin to experience symptoms such as swelling and increasingly severe pain, which is outside the boundaries of erythema. The overlying skin can become indurated, shiny, and warm to the touch, with eventual development of hemorrhagic bullae. What initially might appear to be a simple cellulitis can then rapidly progress with both systemic and local symptoms. Now, if anaerobes are involved, subcutaneous emphysema can also be appreciated, as these microbes produce carbon dioxide gas from anaerobic metabolism. Eventually, the infection causes the small vessels in the area to thrombose. This can affect superficial nerves, manifesting as reduced pain and even full anesthesia in the more central areas of infection. Tissue necrosis then develops due to this disturbed blood flow. The term dishwater pus is often used to refer to the grayish fluid seen during a tissue cut down at the border of erythema, in order to perform a fascial biopsy and finger sweep of fascial planes. This can help as a clinical indicator of necrotizing infection versus another sort of infection, but is not always present and is certainly not a diagnostic requirement. Now, patients might seem well and stable, or may only report general symptoms such as malaise and pain, but as the infection progresses, they can quickly develop into septic shock within just a few hours from initial presentation. Since the initial appearance can often mimic a bad cellulitis, regular assessment is important to track symptom progression. To track the spread of redness, the wound should be outlined, dated, and timed. Gram-positive cocci are most often to blame for neck fash, with species such as staph and strep over-indexing as causative organisms. Group A beta-hemolytic streptococcus in particular accounts for up to 40% of all cases. Polymicrobial infections include involvement of gram-negative and anaerobic organisms such as Pseudomonas, Clostridium, and coliforms. Type 1 necrotizing fasciitis, referring to polymicrobial infections, more commonly develops in patients who are immunocompromised, elderly, or diabetic. Type 2 infections, which are monomicrobial, are more often seen in healthy patients. Type 3 and 4 are more rare entities, respectively comprising marine or Vibrio infections and fungal or immunocompromised infections. Regardless of etiology, necrotizing fasciitis is a surgical emergency that is both limb and life-threatening for patients, requiring urgent and early intervention. When seeing a patient for possible necrotizing fasciitis, identify any history of trauma to the skin barrier and clarify the timeline of symptom development. Review the patient's background for risk factors such as immunosuppression, no fixed address, or IV substance use. On physical examination, first review the patient's vitals and level of consciousness to help determine if septic shock is of immediate concern. Then, focus in on the area in question, examining the skin for changes such as erythema, bullae, drainage, or necrosis. Feel for temperature, crepitus, and pain. If pain is out of proportion to the visual appearance, or if pain is felt beyond the borders of erythema, this would be a concerning sign for a necrotizing infection. During the exam, mark the edges of the erythematous margins with the date and time. This is helpful to track progression of skin changes. Don't forget that the presentation of necrotizing fasciitis can be quite varied, so always keep your index of suspicion high, even if only a few signs or symptoms fit into the picture. Initial investigations include labs with possible imaging and bedside cut-down depending on clinical context. Basic labs should be ordered, including a lactate to assess for tissue hypoxia and hypoperfusion. Creatine kinase levels can be elevated in later stages of infection, and this is indicative of myonecrosis secondary to ischemia. Imaging modalities such as CT or ultrasound can help show hallmark features such as soft tissue gas, as seen as the image below, fascial thickening, and fluid collections. These can be helpful to aid in the diagnosis but are not required. Imaging should never delay proceeding to surgical management if the clinical presentation is clear. The gold standard for diagnosis involves wound exploration and biopsy. To confirm or rule out a necrotizing infection, a bedside cut-down is often used. This procedure is done under local anesthetic at the bedside. An incision is made at the area of concern, and dissection down to the fascial level is performed. In cases of necrotizing fasciitis, murky, dishwater-looking fluid can be appreciated along the superficial aspect of the deep fascia, and when using a finger to sweep along the fascia, it will easily separate from surrounding tissues. These clinical findings are consistent with necrotizing fasciitis. Additionally, a fascial tissue biopsy can be taken at this time and sent for immediate pathological assessment with gram staining and culture to better narrow antibiotic therapy. The L-Renex score is sometimes used to help distinguish necrotizing fasciitis from other soft tissue infections such as severe cellulitis or abscess, although this is more common in primary care or emergency departments and is not routinely used by plastic surgeons relying on clinical findings. This tool has been shown to have variable sensitivity and should never be used to rule out a necrotizing infection. Using 6 independent variables, namely CRP, white count, hemoglobin, sodium, creatinine, and glucose, a score is yielded to estimate the risk of a necrotizing infection being present. The 3 primary principles of management are IV antibiotics, surgery, and supportive care, although this can be further expanded to encompass the extensive monitoring, repeat operations, often including tissue reconstruction, and adjunctive treatments necessary in these cases. For any patient with a suspected necrotizing infection, initial and prompt empiric treatment should consist of broad-spectrum IV antimicrobials with activity against gram-positive, gram-negative, and anaerobic organisms. It is crucial to start these antibiotics as soon as possible, ideally after blood and tissue cultures have been obtained. Acceptable regimens include either a piptazo or carbapenem, plus vancomycin or daptomycin for MRSA coverage, plus clindamycin for its antitoxin effects. As soon as gram stain culture and sensitivity results are available, antibiotics should be tailored appropriately. For example, with a group A streptococcal infection, the most common cause, penicillin IV Q4H plus clindamycin IV Q8H is recommended. Combination therapy should be continued until 48 to 72 hours of clinical and hemodynamic stability, at what point penicillin monotherapy may be appropriate. The primary treatment is surgical debridement for source control. The quicker these patients can be brought to the OR, the better their prognosis and the faster their recovery. All necrotic tissue needs to be aggressively debrided and irrigated. After hemostasis is ensured, the wound should be left open and packed with wet betadine-soaked gauze or a similar dressing. The wound is checked regularly to monitor for further deterioration. Patients with nec fasc often require several trips back to the operating room for repeat exploration and debridement. Once all infected tissue has been removed, negative pressure wound therapy, such as a VAC, can be used to help promote granulation tissue and speed up the wound healing process. Depending on the degree of soft tissue damage resultant from the infection, reconstruction may also be necessary, although patients must be stable and well clear of infection before proceeding down this road. In these pictures below of necrotizing fasciitis of a patient's thigh, you can appreciate the characteristic tissue necrosis, lack of tissue adherence to fascial planes, and dishwater purulence from the wounds. If not already toxic upon presentation, these patients can quickly deteriorate into septic shock, resulting in diffuse capillary leak and refractory hypotension. Following initial surgical debridement, ICU admission and close monitoring is warranted, with patients typically requiring aggressive intravenous fluid resuscitation and vasopressors. In addition to continuous monitoring of vitals, wounds should be reassessed regularly, often as frequently as every hour, given how quickly this condition can progress. Nutrition, specifically protein intake, should be optimized for wound healing and is a key part in recovery to help offset the negative protein balance secondary to catabolism from the wound. Enteral feeds are always preferable, but sometimes parenteral nutrition is needed to keep up with these requirements. There have been several described adjunctive therapies that can be used in the treatment of necrotizing fasciitis, although these are not by any means substitutes for our mainstay principles. Hyperbaric oxygenation is postulated to enhance recovery by increasing oxygen delivery to hypoxic tissues, thereby reducing edema and providing antimicrobial benefits via reactive oxygen species. Some studies have shown decreased morbidity and mortality with this therapy, although more robust research is needed to confirm these findings. Additionally, as most patients are hooked up to numerous machines in the ICU, physically getting them into hyperbaric oxygen treatment chambers is quite difficult. Intravenous immunoglobulin has also been used with some success in the treatment of neck fash. Containing antibodies against Clostridial and streptococcal toxins, it is theorized to reduce the burden and severity of infections. For this to work, the causative organisms would have to include these species, and again, more robust research is needed to confirm the benefits. Lastly, and a key step for plastic surgeons, comes the management of the resultant wound once the infection has been eradicated and the patient well stabilized. Primary closure is often not feasible due to the extent of debridement required for necrotizing fasciitis, and so we thus rely on the reconstructive ladder principles to guide soft tissue reconstruction. Working our way up the ladder according to the defect size, characteristics, and location, these wounds can be reconstructed using skin grafts, local flaps, or free flaps, becoming progressively more intricate to perform. Now, as mentioned, necrotizing infections are scary and dangerous entities that can lead to organ failure, shock, and ultimately death if not appropriately managed. This is why ICU involvement is of crucial importance throughout the treatment course. The extensive debridements necessary can also leave patients with severe scarring and even limb loss. In summary, necrotizing fasciitis is a rapidly progressive soft tissue infection that requires a high index of suspicion and prompt surgical intervention to avoid loss of limb and even life. Numerous surgeries are often required to eradicate the infection and reconstruct the tissue defects. A multidisciplinary care team is essential to treat these patients, involving plastic surgeons, ICU staff, infectious disease specialists, emergency medicine providers, and more. Thank you for watching this video, and I hope you learned something new. Please feel free to reach out with any questions and check out our numerous other videos for more plastic surgery topics.